Hello, everyone, and thank you so much for joining us today for this event. My name is Andrew Pinto, and I'm a physician scientist and director of the Upstream Lab at the University of Toronto, and really pleased to host this event that's going to feature 7 different models of innovations in addressing social needs in primary care. So we're going to begin, as we now do in Canada, just acknowledging the land on which all of us are living and working today. We are coming to you from 5 different cities in Canada, and I'm going to start by acknowledging Toronto, where I'm located, is the traditional land of the Huron-Wendat, the Seneca, and the Mississaugas of the Credit River. And today, of course, this is home to many Indigenous people from across Turtle Island still, and we are very grateful to be here. I also, when doing land acknowledgement, want to use the chance to amplify work by colleagues, and I just wanted to point to the National Collaborating Center for Indigenous Health and some of the amazing work they've done on social determinants of health that you can find here. I'm going to turn it next to Simone, who's going to acknowledge Ottawa, where she is located.
Yes, thank you. I'd like to acknowledge the land on which I'll be presenting today is the unceded territory of the Algonquin Anishinaabe people. The Algonquin people have lived on this land since time immemorial, and I'm grateful to be able to present on this land.
Thank you. I'm going to turn it to Gina to talk about Hamilton.
So McMaster University is in Hamilton, and McMaster recognizes and acknowledges that we are located on the traditional territories of the Mississauga and the Haudenosaunee nations, and within the lands protected by the Dish with One Spoon, One Pump agreement. And I'm grateful to be able to present on this land today.
Thank you. And Jay, do you want to go next for Winnipeg?
Good morning, everybody. In the spirit of reconciliation, we acknowledge that Manitoba is the traditional land of the Cree, Ojibwe, Oji-Cree, Dakota, and Dene people, and the homeland of the Métis Nation, and we are on Treaty 1 territory. Happy to be joining you.
Thank you, Jay. And then finally, Cheryl, who's located in Halifax.
I would like to acknowledge that from where we present, we are in Mi'kma'ki, the traditional and unceded territory of the Mi'kmaq people. We're grateful to be here.
Thank you so much, everyone. So this work that we're doing at the Upstream Lab is supported by funds from many different organizations, but specifically related to this large project called the SPARK study. And CIHR, Canadian Institutes for Health Research, is our main funder, but we also receive funding and in-kind support from a variety of other organizations, as you can see here. The Upstream Lab is a research team that's based in Toronto, but we are fortunate to work with colleagues from across Canada and outside Canada. And this is just a brief graphic that shows our work is at these 3 overlapping areas around integrating health and social care, proactive care for learning health systems, and population health management, and some examples of the areas we're working on. And one of the things I want to just note is a few years ago, we published a framework for how health organizations can tackle the social determinants of health. And this, you know, at the time, 4 or 5 years ago when we published this, I think it was still a really new idea and concept that health organizations could mount responses to social determinants. And this framework kind of starts with the idea of data at the top, and then how can influence individual care, practice management, and then also flow upstream to tackling things at a population level. And today's presentation, these 7 different models kind of fit at this level of how we can change individual care for patients, and also a bit about how we change things at the community level as well. So I'm going to turn it now to our amazing presenters. You can see here we have a really incredible group of folks, and I'm going to introduce people each as they are presenting And each person is going to present for about 6 minutes or so. So it's a pretty tight presentation so that we have lots of times for the question and answer part of this. So just a reminder, as you are hearing people present, if you have questions, feel free to put them in the Q&A, and people can vote on those questions if they are ones that really appeal to you, and that will bring them up higher on the list. So I'm going to start with Dr. Simone Dahrouge, who's a wonderful colleague, and really appreciate her presenting today. She's the population health scientist and associate professor at the Department of Family Medicine at the University of Ottawa. Her team has co-developed this patient navigation program with patient partners, with decision makers, and with providers. And as you'll learn, it's the Access to Resources and Community project is now being studied in the context of the COVID pandemic. So I'm going to turn it over to you.
Thank you. So maybe we're not seeing everyone here, but I want to begin by acknowledging the wonderful team that I've worked with throughout the development of ARC, and I think hopefully they're all you're able to see them all here. I also want to especially thank Lisa Dolovich for supporting ARC at its inception and allowing us to crib some of the tapestry work that they had done. Thank you. So this project came about because the region where we were had identified low access to health enabling resources, and especially inequitable access. So we undertook this project to overcome that inequity. Patients told us that they had difficulty navigating the system. What's available, where, for whom? Do I have to pay for it? How do I register? I don't understand this, this form. So they commonly face barriers that require support, and many folks don't have the support necessary to achieve access to services that's going to help them address unmet health and social needs. This is especially true for the more complex patients. So patients who live with some social vulnerability and who in fact are the most important recipients of these types of services. The appropriate place for support of these individuals in our mind, or at least one important place, is primary care. So we consulted with primary care about their experience in supporting patients, and they said, well, we have limited awareness of what's out there. There's tons of stuff. And we're talking about all these health enabling services, like for healthy eating, so healthy behavior, and those that address the social determinants of health. Many of these are in the community, and some of them are part of government programs. So they didn't know everything that was available, and that makes sense. And neither did they have the time to support patients. So in consultation with a group of stakeholders, we developed the ARC model. So yeah, so the ARC model essentially consists of a navigator supporting multiple practices. Primary care providers identify patients with health and social needs, make a referral to the navigation services. The navigator then takes on that individual, meets with them, and understands their priority, understands their needs, their potential barriers, and helps link them to the service that can best address their need. You can see here some of the work that the facilitator does. It's essentially overcoming barriers to ensure that that link happens. So what are the key elements of this model? Okay, first, it's embedded in primary care. That means a broad reach. Most of the population have primary care providers. Because it's in primary care, patients often don't even realize they may have a need, or there may be support out there for a need that they have. So the primary care provider can help them identify this. Also, recommendations from primary care providers help improve compliance with action on these needs. The navigator serves as a link between the community sector and the primary care sectors. So it improves sector integration and continuity of information. The individual is a lay navigator, so that's more cost efficient. They're not addressing clinical issues. They apply motivational interviewing and follow up with the individual until they close the loop and they were able to have the patient access the resources that they need. We offer whole person navigation so that one individual doesn't have to go to different navigation support to receive the help that they need for various needs that they may have. They may have multiple needs, but one navigator can help address all of these, and whether related to health behavior or social determinants of health. And finally, it addresses an important gap in the system. There isn't any broad-reaching initiative to help support patients who are socially vulnerable access resources that they need. So because it's available within primary care, it helps reduce system fragmentation and it can reduce inequities in care. So the limitation is that there's a cost associated. Sometimes patients aren't ready. Despite great navigation, we're not able to help the patient reach the resources that they need. And for some patients, this is insufficient support. They need more in-depth support. But let me tell you where it does work. We compared ARC to 211 navigation services. Patient experience was excellent in ARC across patient profile. For providers, it especially worked well in capitation, non-interprofessional models. The interprofessional practices didn't really appreciate it. And finally, there's evidence that it can actually help reduce gap. You can see here that the effect of ARC on access to services across education level has reduced the gap between education level, whereas the 211 has not. So those with university degrees are 50% likely to access a resource, but those without a university degree are almost as likely in the ARC arm, but not the 211 arm. This is our vision, that it be embedded in primary care and that there be a merger between the ARC model and the 211 to reach the broad community. Thank you. So this is, I think, a slide that we're all doing. So who are we targeting? Any individual that needs support for health and social need. What are the key aspects? Lay navigator, in primary care, excellent communication. How does it help? It helps reduce unmet needs and leading to closing the gap in health across social strata.
Thank you so much, Simone. That was wonderful, and really appreciate you packing in everything into a short presentation. That was fantastic. So next I'm going to turn it to Dr. Lisa Dolovich, who is a professor and the Dean of the Leslie Dan Faculty of Pharmacy at the University of Toronto. She's also a professor part-time in the Department of Family Medicine at McMaster University. And you heard from Simone's talk, there's a link between Dr. Dolovich and the work elsewhere. And within her role at McMaster University, she was one of the co-founders of TAPESTRY that you're going to hear about and that she's going to speak to. So thank you so much, Lisa.
Great, thanks so much, Andrew. It's really a pleasure to be here. Really pleased to be able to present Health Tapestry on behalf of my colleagues, David Price, Dee Meng, and Doug Oliver, and many others, including Gina Agarwal, who's here on the phone, as well as connections with a number of the other presenters. Health Tapestry is funded by a number of different funding organizations that were listed on the first slide, including Health Canada and the Government of Ontario. And so we thank them for that funding as well. So we have a short period of time. I'll do my best to tell you a bit about Health Tapestry. Really our intention at the very beginning of thinking about this model, which was back in 2012, 13 or so, was to address how we can help people stay healthier for longer in the places where they live, with really something centered in primary care. There are a number of components I'm going to talk about shortly, but in the next slide, I'll ask Rose to go to the next slide, please. I'm going to give you a bit of a description of how this works. So we, in this model, we train volunteers from the community to go to people's homes and really ask them about what matters to them and how they are. And we do that by having the volunteers who've been trained get to know the person in their home through questions that are from structured questionnaires, asking them about their health goals, their health needs, as well as some open-ended questions just about how they are. And those answers are recorded digitally on a tablet computer. And a number of the questions ask them about things like social isolation. So this gets to how can we start to understand not just their sort of physical and mental health needs, but their social needs as well. And then all of those responses that the volunteers from the community gather are formed into a report, which gets you to number 3 if you're going around the clock. Number 3 that go into a report that is delivered electronically to that person's primary healthcare team. And that team gets together, if you go around the circle at number 4, to prepare a care plan. And that care plan includes the team sometimes interacting different healthcare providers with that person in their home. Or that person comes to the clinic, or the volunteers also interact in certain ways with people in their home. And they connect also that person with community resources in various ways, depending on what health and life needs and goals are identified by the person at the beginning of the process. So then it becomes an iterative circle where we hope that the person in their home is connected better to the primary care team, as well as resources in the community, and that their care continues with that type of connection. So key ingredients for success. This is really a multi-pronged approach where we have trained volunteers from community organizations working with people in their home. We use new digital technology, including tablet computers, including changes to our electronic health record and other aspects of the technology. We engage community in terms of organizations and resources that we want to incorporate into the process. And our interprofessional care team, including aspects of system navigation, really comes together, meets more carefully, I think, and cohesively about that person to plan that aspect of care more wholesomely, I think, for that individual. Everything is recorded as a care plan in the primary care team, and the person themselves is sent a copy of the summary of what the team's committed to doing. There are a number of limitations to this and challenges to get this multi-pronged approach up and going and continuing. There's a lot that we have to deal with in terms of technology, how to make sure it's being able to be used well during home visits, it's available to the volunteers that are being trained on it, and it's connected to the primary care record. From a volunteer perspective, we pay attention to the scope of the volunteers and the role that they have so that they're embedded well within the system. And I would say we didn't do that so well at the beginning, and it's gotten better and better over time. Making sure that there's volunteers available and making sure the volunteers are trained, and also to address the focus of the visit. So which questionnaires are incorporated into the app that we use, our TAP app, and what questions form the basis of narrative reports. We're working in Health Tapestry now with the Canadian Red Cross, and so that's providing an element of being able to scale up, of course, across various places where the Red Cross works as well. But we're also working with volunteer organizations that are separate from the Red Cross in some of the communities right now too. From the healthcare team perspective, it's a real difference in terms of workflow. So there had to be a lot of work done to figure out how to embed this into our primary care team practices, and also just to have certain healthcare providers know more about what other healthcare providers did. So it was a learning opportunity for everybody to try to make sure this happened. These are only some selected limitations and challenges. I could spend another day talking to you about this, but I think we learn as we go, and it's definitely iterative improvements over time. Number of contextual factors, again, just some selected ones here. The volunteer and healthcare sector partnership was really important to ensure that that's working well. The culture of the primary care team to be considering a number of aspects that were raised that maybe were less identified before, and embedding this into practice and having the technology that can be really adaptable. The data that's being collected also can help the primary care team as a whole, because they can start to see gaps. Once you amass data from 300, 400 patients or participants, you can see that there's care gaps. So as an example, we found that 35% initially had issues with urinary incontinence, but the primary care team didn't have a program that was related to that. So that was something that was identified and then rolled out on a more whole practice perspective. So what Andrew said before about there's how data can be used at the individual and then also at the population level was certainly occurring within Health Tapestry. Another contextual factor is just evidence. So we really tried to amass qualitative and quantitative evidence along the way and share that with individuals so that they could see how the model was working. The last slide that I have the opportunity to share. So just in summary, our target population so far has been older adults living at home, and they're reached by primary care invitations. The key aspect of the intervention is that information is gathered by home visits that are carried out by community-based volunteers, transmitted electronically and followed up by the primary care team and volunteers and actually community organizations in iterative cycles. And how the intervention helps is it identifies previously unknown and issues that can be identified, including social issues by the care team, and can also be more proactive in addressing issues already known. But now there's another connection point between the person and their family in their home with the healthcare team. And we've shown also in terms of how this intervention helps that it reduces ER visits and hospitalizations. We did a randomized controlled trial that was published in CMAJ that showed that we do have a positive effect on health, on the reduction in healthcare resources. So it helps in that way as well. Thank you very much. It's been a pleasure.
Thank you so much, Lisa, for that fantastic presentation about Tapestry. Really, really exciting work. I'm going to now turn it to Laura Boodram, who is an income security health promoter at the St. Michael's Hospital Family Health Team. She also is part of the Social Determinants of Health Committee and also the Advocacy Committee for the Family Health Team. And she's been serving as the co-chair of the COVID-19 Working Group for the Family Health Team. She has 16 years of experience in the social service sector in a variety of areas, including helping folks dealing with brain injury rehab, mental health case management, and health promotion. And it's a real pleasure to have her talk about the Income Security Health Promotion Service.
Thank you, Andrew. I wanted to really thank Andrew Pinto and Dr. Gary Block, as well as my colleague, Carnell Williams. Next slide, please. So as you can see, this is the Family Health Team at St. Michael's Hospital. We serve the downtown East Toronto, about 50,000 plus rostered patients, 75 physicians, and 100 ally health providers. We have a strong focus on the social determinants of health at our 5 locations. So here is the Income Security Health Promotion Department, and what some of our key areas of success is really improving access and removing barriers. So we have 3 main focuses of our department. One is increasing income, reducing expenses, and building on financial literacy education. So just a little bit about each section. Applying through social benefits is an excellent way to increase people's income, including government benefits, completing taxes, applications for disability tax credits, referrals for job search, resume writing, and second career navigation. Through the reducing expenses section, and just to keep in mind, this is sort of like a nice little care package that we provide to our patients at our family health team. So within the reducing expenses piece, we look at areas of budgeting exercises to find the most appropriate community referrals sent to our patients, as well as like examples of Connected for Success program or the low income hydro program, just to name a few, as well as credit counseling for referrals for patients with debt. Finally, our last pronged approach would be the building on financial literacy. This is to improve access and referrals to financial empowerment workshops on retirement planning that myself and my colleague at the FIT are currently working on, as well as collaborations with the social work team to teach coping skills for financial anxiety. So as you can see here, this is sort of like the objective of the Income Security Health Promotion Service within the Family Health Team at St. Michael's. And as you kind of move through the program, you would see the different outcomes throughout. The first, as I mentioned in the previous slide, there's 3-prong approach, which is the increase of income, reduce expenses, and the overall financial literacy. And that is our direct way to improve individuals, families, and communities served by the Family Health Team. So you'll notice that we have, at our FIT, we have 2 health promoters, and the activities we do would be one-to-one meetings, whether it's in person, over the phone. We do workshops, seminars, and group interventions, as well as tax clinics and education for patients. In the outcome, we look at the short-term goals. We look at the number of patients referred, the number of patients seen one-to-one on our encounters, and then patient self-reports, increased knowledge of financial benefits, grants, debt management services, and so on. We also look at the percentage of patients who received financial relief as a result of the services provided, as well as the percentage of patients that report the increase in financial confidence overall. Some of the midterm level areas we look at is increased income, improved employment status, and increased financial literacy. And the longer term goals of the program is really to improve health quality of life and improve the access to services. Some things that we see that are kind of assumptions through the work that we do is that there's less entitlement that patients do not have access to, and a lack of information or the ability to navigate systems. Providing patients with information on one-to-one support will actually help improve the income security. Some of the external factors we look at is that growing a public awareness of the social determinants of health, addressing income security fits the mandate of the Family Health Team at St. Michael's Family Health Team. So some of our key ingredients of success is access to specialized support around financial challenges. We remove barriers to accessing financial supports. We serve the most vulnerable and marginalized populations. We engage in a lot of advocacy and ensuring our patients have a voice. We're situated in an engaged family health team that has a strong focus on the social determinants of health, and access to medical legal partnership with the health justice program. So some of our contextual factors that impact our success, this is our referral pathway. So how you would refer a patient through our primary care provider team would be through the centralized hub form that's located on the patient's medical chart. So this is how the hub model continues to have success. The centralized hub is comprised of the following members: psychology, social workers, income security health promoters, addiction outreach workers, and access to psychology training clinics. We meet weekly to discuss new referrals as well as complex cases. We have an integrated care team that allows us to have access to consults on an as-needed basis. Consults can include case conferencing meetings with doctors, nurses, pharmacists, residents, as well as the diabetic teams to ensure that our team is providing equitable access to care and addressing the ongoing needs of our patients. So some of the limitations and challenges that we've seen as the income security team has seen quite a few barriers lately, and have had it has had us pivoting and creating systems to support our patients a little bit better. So once the patients get connected to community organizations, we notice the loop of communication is not the same as our integrated care team. As service providers, we notice that not having all of the information on each case, a patient may get lost in the system. This results in many patients having to retell stories as well as complexities of each case increasing as a direct result of ongoing health issues. You know, during our work during COVID-19, we've seen community resources have been experiencing high levels of referrals and wait lists have increased. Therefore, the caseloads have been higher to support the level of need in the community. COVID-19 has actually shown us the gaps in the system, and as a result, St. Michael's Family Health Team, the income security health promoters, along with social workers, NPs, doctors, and other service providers in the community, were able to provide and build a marginalized and COVID Google resource drive that helped us access services that were open during the pandemic. This drive has been the resource that we needed to provide equitable access to care and quality care to the population we serve. Some of the limitations and challenges that we see, just to name a few examples, some individuals with disabilities have had less supports right now during the pandemic and less income or have had their income cut off during the pandemic. What we do is we'll connect with the service providers and provide advocacy to ensure that they are receiving the benefits that they need and have access to food security resources to ensure basic needs are met. At our clinic, we also noticed the aging population needed assistance with tech serve and tech literacy workshops on how to use Zoom and increasing email navigation, as well as navigating CRA websites and My Service Canada benefits. We also noticed that we've put into place Introduction to Retirement workshop for financial education. As a direct result of COVID, the Income Security Health Promotion team has taken on roles of service navigation and longer-term case management to continue to provide support for each complex case. This might mean that we might bring other service providers within the St. Michael's care team to provide continuity of care. So in summary, as you can see, the population that we serve is low-income individuals and families within the Toronto area, individuals living with disabilities, and this is only accessible through St. Michael's Family Practice as an internal referral. Some of the aspects that we see in the intervention itself is to increase overall income, reduce expenses, and increase overall financial literacy. So we look at how this intervention helps. We talk to our patients, and we know that by applying for income security programs, completing budgeting, and assisting with reducing expenses, it provides a level of quality care for individuals that we serve, and it improves the quality of life for them. And, you know, just to name a little bit more about the research project that Andrew Pinto is doing, it will measure the effectiveness of this program. Thank you, everyone.
Thank you so much, Laura. That was fantastic. And indeed, we are concluding a randomized control trial around this service. Really excited to see the results.
Me too.
So next, I'm going to turn it to Jay Bodner, who is a registered nurse by training and is serving as the team manager with the Winnipeg Regional Health Authority's Downtown Point Douglas MyHealth team. And he's going to talk a bit about this. Prior to joining the Winnipeg Regional Health Authority, Jay was the Director of Primary Health Care at the Mount Carmel Clinic and the Aboriginal Health and Wellness Center in Winnipeg. Thank you so much, Jay, for joining us.
Good morning, everybody. Thank you for having me. I realize I need to step up my PowerPoint game because I have nearly zero cool graphics. Model we're talking about here is the MyHealth team in Winnipeg. And I do, as Andrew said, I do represent the Downtown Point Douglas community. Downtown Point Douglas is the most impoverished, marginalized, yet super vibrant neighborhood in the city. So back in 2010, Manitoba Health did a study which identified that 94% of primary care clients were being cared for in private practice, which is a common, this next part is a common theme, which many of our presenters have said. A lot of these private practice clinics, fee-for-service, had no relationship to the larger health system. It's very difficult to give the whole inception of MyHealth teams, so it's 3 quick little bullets. So out of that study, Manitoba Health developed the initiated some primary care renewal activities, which included the MyHealth team, family doctor finder, and the what we call ITDI, interprofessional team demonstration initiative. To assist in building an integrated one system approach to primary care, really to support access, some continuity, and comprehensive care for Manitobans. And out of that, there are now 6 MyHealth teams in Winnipeg, and comprising about almost 70. In fact, we're probably at 70 now, and we are actively looking to engage more private practice clinics as we move forward. So the description, it's a collaborative, formalized partnership between Manitoba Health and Seniors Care, which is our funder. The WRHA, Winnipeg Regional Health Authority primary care programs, which the MyHealth team does fall under the primary care banner. Fee-for-service, private fee-for-service medical clinics, a large component of community health agencies, which are also funded by the Winnipeg Regional Health Authority, but are not direct WRHA operations. And additionally, numerous community stakeholders, various programs, resources, and some examples at the bottom is our home care, public health, community mental health, EIA, employment income assistance, community facilitators, the healthy aging resource team, looking to engage as many partners and stakeholders as possible. And as we discuss this, there often is a ton of crossover. So you could be attached to your physician, your provider, your nurse practitioner, your home clinic, but all these various resources, an individual could be attached to all of these places. So we're often working quite closely with these other resources and programs to make sure we're managing the care with the client. So what is the key ingredient? It's basically, so enhanced client care through these interprofessional teams, relationships, and pathways. I'm sure all of us here understand the different models of physician practice. So, you know, our WRHA primary care providers, the nurse practitioners and physicians, and the community health agency physicians are largely salary funded. Also, these two agencies, these two programs often have more resources than private fee-for-service practice will have at their disposal. And I mean in-house. So you could have primary care nurse, you could have dietitian, those kind of things in-house to refer to. Where in the private practice world, it's, you know, as you know, it's often a 1 or 2 physicians or a small group of physicians with front-end reception or primary care assistant and no ability to refer in-house. So everything goes to a centralized, and you're often searching for the right resource. So the MyHealth teams, we are comprised of various different roles. So as I've shown here, it's difficult to speak for all of the 6 MyHealth teams, but there is a theme of chronic disease management clinicians, which are often certified diabetes educators, respiratory educators, OT and PT, income security health promoter is a rapidly growing role, very valuable role on the teams. A large component of social workers, pharmacists, nurses, dietitians, mental health, addiction, counselor support workers. Some of the key ingredients to success also includes a low barrier referral method. So the partners who've signed on, there is a MyHealth team agreement that partners clinics will sign on, and there's some deliverables that we don't have time to discuss here. But so the referral pathway, it's a quick and easy fax to the MyHealth team or tasking through the electronic medical record system. And it will go right to the team, and then the team will vet the right person to take up that referral. So on my team, I have 6 clinicians currently and 2 outreach workers and a very small amount of admin. So referrals will come in, and our partners generally know what resources we offer. But also, if we don't offer this in-house, we do assist in connecting to the appropriate resource. So limitations, as a common theme here, is the social determinants of health. It's a constant challenge in all neighborhoods that our 6 MyHealth team service, but definitely that's definitely the case in downtown Point Douglas. Social determinants of health are something we battle every day. It's something we say every day. It's in our focus every day. While we're very excited to have this complement of different types of roles on our team, like my team has the income security, we have an OT and a chronic disease. We can do stuff like OT. We can see clients in their home. We can see clients in their on-site here. We can see clients in their home clinic as well. Any one of our staff, we're very mobile, we're very flexible. So the financial challenges kind of come from, oh, wow, wouldn't it be really great to have this resource to address this social determinant of health? Mental health in this province is mental health resources. We're trying really hard, but it's quite a challenge, especially long-term. We deal, our MyHealth team deals with a lot of homelessness, shelter populations as well, who are connected to many of our partners. Transportation is a massive barrier. Winnipeg is a city where you kind of need a car. Buses, it's not really that easy to get around. And certainly the current apocalypse that we're all dealing with has just taken everything right to the next level. One interesting thing, due to how we're funded, that once we engage with partners and physicians, each partner each MyHealth team clinician that we have on the team is voted on by our partners. So we will, whether that's an informal community assessment or identifying specific needs, then we vote to see what type of services are the most appropriate, reasonable, and realistic. So my team started off with 1 chronic disease management clinician who was a psych nurse by background, and also diabetes educator, and then it has grown to what we are right now. So the 6 clinicians and 2 outreach workers, that's just my team. So I spoke a little about the flexibility, mobility to see clients in their home clinics, kind of meet the clients where they're at. I said we can work with partner clinics. I can have our staff located at your clinic a day, maybe not a day a week, but a couple times a month. So your clients will be seen in your clinic. They don't have to get on a bus and go to a hospital, let's say for spirometry or a diabetes educator. For individuals who, are dealing with living in poverty. Maybe they don't have enough minutes to waste on a phone appointment, or they don't have the technology or Wi-Fi. So we are very mobile. We can go to see you. Most of my team right now is out in the field. We do focus on access, really low barrier outreach and service coordination. And the other thing that's very helpful is the electronic medical record system. Just contributes to that improved communication and timely access. Summary. So who is the target population? There's 6 MyHealth teams. So it is the target population is the individuals residing in those communities. So somewhere in a more maybe affluent, individuals in a more affluent neighborhood still are deserving of quality healthcare. Again, my team is dealing with, you know, the most impoverished community in the city. And those clinicians on those MyHealth teams were voted and created based on the needs of that community. Key aspect of intervention is that low barrier, timely access. For my team, how do we remove the most barriers possible? What are the barriers to vulnerable or at risk of marginalized individuals trying to access the system? And then how do we address that? How does this intervention help? I didn't say relationship building. We don't do a lot of longer term care. At least the mandate is not longer term care. However, our MyHealth team, we end up doing longer term management just due to people's living situations. So striving to become a trusted point of contact, striving to be a friendly, non-racist face in this system, and addressing and removing the barriers. And I think the next slide is contact information. Thank you very much.
Thank you so much, Jade. That was really fantastic. Next, we're going to have Dr. Jennifer Rayner, who is the Director of Research and Evaluation at the Alliance for Healthier Communities in Ontario. It supports more than 100 community-based primary care organizations in the province. Dr. Raynor is an applied health services researcher and has strong interest in primary healthcare, interprofessional teams, and health equity. She's an adjunct research professor at Western University and also an associate professor at the University of Toronto in the Institute for Health Policy Management and Evaluation. So Dr. Raynor is going to talk about social prescribing.
Great, thanks, Andrew, and thank you all for the opportunity to present our work on social prescribing. So it's so great to be part of this panel that is discussing social determinants of health and their impact on health and well-being. We know that health is impacted by a variety of these factors, and we're increasingly recognizing the importance of having a sense of connectedness to others. So in Ontario, to sort of try to address some of these social determinants of health, we, the Alliance, implemented RX Community, which was a social prescribing pilot project in which 11 diverse CHCs implemented social prescribing into their clinical pathways. And for those of you who are not familiar with community health centers, they're basically set up to serve people who face higher barriers to health for a variety of social and structural reasons. They deliver a range of medical, health promotion, and social and community support services. So if you think of a doctor's office nestled within a community center or hub, that is really the context in which we implemented our pilot project. So here's what we did. Because our pilot centers are comprised of a diverse mix of organizations, social prescribing really looked different depending on where we implemented and the particular resources and needs in each region. But really, we were able to distill 5 core components within the social prescribing pathway. And this was really what we felt was really required between primary health care and these non-medical supports, which were key to the project. The first step was recognizing that a patient or client is an individual with medical needs, as well as social needs, but ultimately they're more than the sum of their illness and also have interests and gifts to give. The second component is the prescriber, a primary care provider who is able to identify when the patient they're seeing has underlying needs that can better be addressed non-medically. This provider was really significant in the pathway due to their trusted relationship with the clients. But we know that a healthcare professional is generally not the best suited to maybe address all of these folks' individual social needs. So that's where we used a navigator or a link worker, and this was the third part of the pathway that was quite critical. They receive the referral from the health professional and can spend time with the individual to understand their interests and needs and support them to connect with other services. Finally, we have the actual prescriptions, which ranged from coffee meetups to dancing to peer-led museum visits to support groups, as well as opportunities to co-create their own solutions, which I'll come back to. And then we have the whole data and evaluation piece, which we described as the fifth component. And this was really important to understand and share the impact and feasibility of the interventions, but also really helped identify gaps in the social prescribing pathway, which helped us to continuously improve. I'm only going to highlight a few key ingredients specific to the pathway just discussed, and then I will quickly talk about some results and some limitations and lessons learned. So I think the first key ingredient I wanted to focus on was really what differentiates this activity from usual practice. So it supports participants or patients to bring their interests and gifts to co-create and be part of the solution. And as a result of this, we had a number of amazing programs evolve out of this type of collaboration. And what we found was when people were invited and supported to co-create the solution for themselves and others, this resulted in large improvements in their feelings of connectedness, in their self-confidence, their sense of purpose, and their sense of belonging. So here are just a few examples, and we've got so many more. The pictures reflect on this slide a friendly visiting program in Collingwood, and a soup and crochet with Grandma Penny in Guelph. And other examples include games, dinner meetings, art classes, photography courses, bereavement groups, social outings, even fishing clubs. So we really span the gambit of interests. Another key aspect to this project was really flipping the usual interaction with a patient on its head. And we heard this from Lisa as well. So rather than asking what's the matter with you, we reframed the question to what matters to you. And this enabled healthcare providers to identify clients' non-medical needs, but then again, have a pathway to ensure they got the support they needed. Again, this is where we found that navigator or link worker really, really important because they received the referral. They had the time to spend additional time with clients to understand their interests, their needs, and their individual circumstances. And from there, they could connect them to resources in the community and support and follow them up to ensure that they were actually following through with those referrals, but also to address any barriers that they might be impacting that service for them. The third key ingredient were the actual prescriptions. And these reflect the support or services that a person could be referred to. So within our project, we had internal resources. And this was the strength of having this rolled out in community health centers, which often already provide community supports and programming within clinical spaces. Then we have all the external resources. What we did at the very beginning of the project was identify, we built these asset maps. And this was just a task that included drafting up all the existing connections and assets in the community and really built a network of local relationships. And this is where the term social prescribing was really successful in sparking people's imaginations and encouraging non-traditional partners such as arts and cultural organizations, libraries, parks, and so on. The third resource was my favorite, and I mentioned it earlier, and it's really where we invited people to co-create the solutions. So recognizing that clients we served are people with passion and gifts to contribute, we invited them and supported them to become these sort of super volunteers who worked alongside the clinical staff to identify needs and co-create solutions. And so in this way, the social prescribing increased interconnectedness in the community, but also built, and this is important, local capacity for community-based non-medical supports. So what did we accomplish with this pilot, and did it make a difference? Our study period was relatively short, about a year, and we had very little resources for evaluation. But despite this, we saw positive results. So generally, we saw increases in self-reported mental health, increases in the types and variety of social activities that people were engaging in, and a large decrease in participant sense of loneliness. We also saw better self-management of health, along with increased sense of purpose and sense of belonging. From the provider point of view, we found over the course of the project, providers increasingly reported that social prescribing was improving their clients' health and well-being, as well as they were seeing a number of decrease in their repeat visits. So as I mentioned earlier, we have we have a full report with a lot of details on our research methods and findings. We've got some journal papers and stories which you can read about our website, and I've got that in the resources. So I've listed some limitations as well as lessons learned. I think the key limitation for this project was we tried to do this on a shoestring budget. We used a lot of our resources to bring folks from the UK who had implemented social prescribing to mentor us on how to do this well. And so this was a minuscule budget for the staff and organizations that were trying to implement it, but also from the evaluation side. So centers really received no additional support to do this work. And so I'd say all aspects were a tricky time to manage, resulting in an ongoing need to manage the data side of things. Staff needed to be redeployed as system navigators and link workers. And, I think some of that resulted in not great survey responses, or some, we had to really be purposeful with our data management. Some key lessons learned was ongoing communication was critical. We really found that leveraging clinical and interprofessional peer champions was key to increasing uptake amongst their peers. So if we had some physician or nursing champion, they could then get their peers on board and also think social prescribing was a great thing to try. Social prescribing was simply not just adding a new structure. It was really about a culture change within each of the organizations. And what it required was to shift the healthcare system of that organization to view people holistically, not just as patients with needs, but also as people with gifts. What we've done since the end of this project, because the evaluation is done, but the social prescribing didn't end. So we've established a community of practice where centers can continue to support each other, and new sites can include social prescribing into their work. So I've added some additional, summary. So this is, I've gone over most of this. The patients were from 11 pilot sites within a diverse group of CHCs. They ranged from Francophone CHCs to Northern to urban, rural. The key aspect of the intervention was that a social prescription was provided by the primary care provider for that client to receive social and supported services. And typically what happened was that person was followed up and supported by a system navigator or a link worker. And the intervention, as I mentioned, really helped with self-reported mental health, decreased loneliness, sense of belonging, and as well as providers, I think time was better utilized, and they really felt social prescribing was improving their patients' health. So a couple of resources I've got are a couple of email addresses for us, and I've got our website, which includes a whole bunch of resources on social prescribing. So, thanks for the opportunity to talk about this project. And just finally, I wanted to thank Andrew Pinto, Donald Cole, Sarah Batty, and Kate Mulligan. They were part of the team that really helped implement this throughout the sector and evaluate it so we could learn. Thank you.
Thanks so much, Jen. It was a fantastic presentation on social prescribing and the work. I'm going to now invite Dr. Gina Agarwal to present next. She's a family physician and professor in the Department of Family Medicine at McMaster University, and also primary care epidemiologist. Dr. Agarwal leads the Vulnerable Individuals in Primary Care Research Lab, which implements a program of research focused on improving health systems for vulnerable populations and ensuring people receive the appropriate care at the right time in the right place. And her work has certainly driven change in Ontario's health system. And she's going to talk a bit about the community paramedicine at clinic program. Thanks, Gina.
Thanks, Andrew. So just a bit of background about the population that the Community Paramedicine at Clinic program, or CP at Clinic program, is implemented in. So our research spanning several years of data collection in social housing has shown some very telling information indeed. Older adults in social housing are at risk of chronic diseases like cardiovascular disease and diabetes, to name a few. Also have higher risk of falls and have poorer mobility. And they also have high rates of mental health problems and social isolation. All of these factors have resulted in higher rates of calling 911 from social housing, and anecdotes have told us that some of these calls are for very purely social reasons like I'm hungry, I wanted to feel reassured, but there wasn't anything really wrong with me, so I just called 911. The CPIC clinic program started in response to this identified issue, and it's now a standardized integrated health approach to care. And it's based on years of robust research, and I'm not really planning to present the details of the research, but if you want to look at that research, I'll tell you where to find it at the end of the presentation. So how does CPIC Clinic work? So as we know, older adults in social housing are vulnerable. And in the CPIC clinic model, community paramedics will visit older adults in social housing regularly, and they offer a drop-in session for patients or residents who live in that building. The paramedics are able to meet with the older adults, and they offer specific assessments that will help these adults prevent and manage chronic disease, and also help them set health-related goals. Paramedics also refer older adults to community resources that will help them meet their health needs. And these resources can include health-related information and also social service-related information. The paramedics become a trusted source of support, and they form bonds, not unlike the doctor-patient bond, with the patients that they serve. So let's think a little bit more about what makes CPIC clinics successful. So community paramedics have knowledge to appraise patients, but really in the acute care setting and not really in a community, more long-term health-related setting. So we offered comprehensive training in some of the primary care assessments to enable community paramedics to be able to follow up with their patients based on assessment results, for example. Also, paramedics didn't have a lot of knowledge around social determinants of health and how they impacted health in the primary care situation. Again, because they're really acute responders. And so we also developed training specifically for this to assist community paramedics in their implementation of CPIC Clinic. Another thing that makes the CPIC Clinic program very successful is the fact that we work very closely in partnership with paramedic teams to ensure that they're very well supported, and so that the program can adapt to different contexts and communities which have different populations. So for example, we work with a Northern Ontarian population that has a mainly Indigenous population, and we work with other populations to adapt the program to their community situations. So of course, any program implementation is not without limitations and challenges. So paramedic service capacity has always been an issue. It tends to ebb and flow, and funding for community paramedicine tends to also ebb and flow, depending on where the community paramedic programs can get their funding from. Sometimes it's provincial, sometimes it's municipal. There's also very much heterogeneity in different sites. So sometimes what might work in an urban setting in social housing may not work in the same way in rural areas where social housing situations are different. They might not have single buildings with large numbers of individuals. They might be smaller buildings or just different. Also in different sites, community resources differ very greatly. And we've noticed that in implementation of the program in some of the different municipalities, how different the resources can actually be. And of course, COVID-19 has placed a lot of barriers on program delivery. We've certainly had to assist paramedic services in adapting their home visits and appointments and providing these in different ways instead of drop-in sessions because of COVID and the risk of infection transmission. So just thinking a little bit about contextual factors that have really impacted the success of the program. So the fact that social housing partners or social housing have wanted to partner with the program has been extremely instrumental in the success of the program. Basically, the best bang for the buck for social housing apartment buildings with the program was where older adults would reside. And also with the fact that the model was drop-in nature and didn't really require people to have appointments booked. It allowed paramedics to be at one location, easily accessed by a large number of patients in a short amount of time. And also with home visits, paramedics are also able to move throughout a building and visit a number of people in a short amount of time because they're all in the same building. And that helps a lot, especially with individuals who have no access or less access to transport. So I talked a bit about paramedic service capacity already, so I won't go over that again. And I also discussed factors with COVID. Apart from COVID, we've been able to advertise the program very successfully in buildings. We would put posters up. Paramedic services also would put door hangers up, flyers, and this has certainly influenced the uptake of the program. And another thing that's influenced the success of the program is the integration of community resources and referrals in the community. So basically the program is very much dependent upon what kinds of resources are available and how integrated they are. And social service availability is also different and varies by region. And where these services are provided, community paramedics, with the knowledge they have from our training, can point patients into the right direction to obtain the necessary social service support and help that they need. So this is just a summary of the CPIC Clinic program. So the program was really designed to meet the needs of older adults with multimorbidity, chronic disease, and lower income. Those individuals were reached through social housing, where the program was mainly located, and also community partner identification helped available resources to be provided to those individuals. And the key aspect of the intervention was chronic disease prevention and health promotion, but we discovered through a series of research studies, one of which was a large multi-center randomized controlled trial, that the program also addressed social needs and improved quality of life of individuals who resided in the building, and also enabled those individuals to feel less socially isolated. Of course, it also reduced 911 calls, which is how I started the talk off, which was definitely an attractive thing to advertise to paramedic services interested in implementing such a program. And how does the program work? Well, as I said, it's drop-in nature, it's mainly in social housing buildings, and it's a health promotion and primary care assessment program. I'm going to end there, but if anybody's interested, please visit our website. It's cpatclinic.ca, and it has lots of information about our studies and randomized controlled trial papers, etc. Thank you.
Thank you so much, Gina. That was fantastic. And we're now going to have our final presentation. And for everyone joining us too, we are going to compile the resources and reports that people have mentioned, and it'll be shared when we post the recording as well. So now I'm going to turn it to Nancy Snow and Cheryl Jeffers. Nancy is the team lead and navigator with the Chiboucto Community Health Team, part of Primary Healthcare Nova Scotia Health, and her background is as a social worker. And Cheryl Jeffer is a navigator also with the Chiboucto Community Health Team, and her background is in recreation therapy. So thank you both for talking to us about the Community Health Team's work in Nova Scotia.
Thank you. All right, so like mentioned, we're going to be talking about the community health teams, and our program is a program that falls under the primary healthcare portfolio with Nova Scotia Health. And to give you a little bit of background, back in 2007, we engaged over 700 citizens, healthcare providers, and community partners to find out how they wanted us to show up in the community. Based on what the community wanted and our knowledge of the health needs of our communities, we started with the first 2 community health teams. And I think it's really important to note that engagement is a key driver of the community health team model. Staff at the community health teams include a team lead role at each of our sites, wellness facilitators who are dietitians and physiotherapists, and wellness navigators. And we're going to talk more about their role in a moment. All right, so this is the community health team service model. The 3 pillars in which we work are group-based wellness programming. So our group program topic areas include reducing health risks, physical activity, nutrition and weight management, mental wellness, and also parenting programs. Under community connections, we work with community partners, health organizations, and other community-based groups. And then wellness navigation, which is our primary focus for today. All right, so this is a little bit about how we work. Wellness programming and navigations are grounded in the behavior change process and self-management strategies. An overall community health team goal is improvement in risk factor management to prevent or better manage chronic disease. We don't do any disease-specific programming at the community health teams. People can self-refer to navigation as well as our wellness programs. We also accept referrals from family physicians and other healthcare providers for navigation services. We offer a person-centered approach, and navigation appointments are guided by the needs and goals that are identified by the client. We recognize that wellness is determined by all the social determinants of health and work to reduce as many barriers as possible to accessing programs and navigation. Our programs and services are free. We have 4 community-based locations, which are all on public transportation routes. We also use community spaces such as libraries and recreation centers to host our programs. And we also provide space in our own sites for our community partners for them to host their programs. And again, with our community and health partners in mind, we aim to avoid duplication of programs and services.
So what is wellness navigation, and who are our navigators? So our team of multidisciplinary navigators all have experience in mental health and consist of social workers, occupational therapists, recreation therapists, and registered nurses. We have a total of 12 navigators and provide service across the lifespan. 2 of our navigators work within a partnership with our local pediatric and women's health center, the IWK. And these 2 navigators provide navigation services to family and youth and programming for parents. The other navigators provide services to adults 18 years and older and facilitate the mental wellness programs. So what does wellness navigation look like? Navigation is a short-term free service to help people problem solve barriers to health goals and get connected to resources and services. We are able to meet with people on the phone, virtually or in person, and we meet with people in our own office spaces, of course, but we can also meet people in the community in locations like library, rec centers, or coffee shops. Again, we're trying to reduce as many barriers as possible to accessing our service. Over the last year, of course, due to COVID-19, how we meet with people has changed. So based on a person's ability or confidence to self-manage, a navigator's role may vary from providing resources only to helping people connect with resources or advocating on someone's behalf. Navigators also work with people on behavior change, both in wellness programming and through the navigation appointments. Navigators provide navigation services to other healthcare providers and to community partners so that we're then giving them resources so they can help their clients. This, of course, recognizing that developing trusting relationship takes time. So we're hoping to reduce barriers to helping people meet their goals by them working with their provider, their initial provider. We also have access to language interpretation services through Nova Scotia Health. So we're able to provide navigation services in any language. Our wellness navigation service is not a long-term service, and we do not case manage. We are not an urgent or emergency service, and we do not provide therapy or traditional counseling. So this graph gives us an example of the type of social needs that are addressed by wellness navigation across our 4 teams over the last 10 years. As you can see, the #1 need identified has been the need for mental health and addiction support. We have seen a shift, of course, in the last year with a significant increase in the need for affordable housing. And of course, since COVID-19, the social, leisure, and financial needs of folks have increased as well. So our key ingredients of success, first being accessibility of our programs and navigation services. Second, through programs and navigation, we're offering knowledge, skills, and practice to help people engage in the behavior change process and to increase skills and confidence of people to self-manage. And of course, our programs are offered by that multidisciplinary team. Lastly, our connections in the community and building relationships with individuals and organizations is a key ingredient. So understanding, of course, our limitations and challenges are key to moving forward and growing. One of our limitations is that our navigation services are currently only offered to residents of Halifax Regional Municipality, not the whole province. This was the same for our wellness programs. However, over the last year, as a result of COVID, we've been delivering programs virtually, and most of these are offered provincially. So changing how we deliver programs has offered us a new way to reach people and to reduce barriers for people who may not be able to attend in person or they live outside of our catchment areas. We are challenged by not being able to provide language interpretation for group programming at this time, and we do not have closed captioning for simultaneous translation during virtual programs. Of course, time is always a limitation and a challenge. So we know that, it takes time to build trust in the communities that we work in or new communities that we might be moving into. And lastly, promoting ourselves has been a challenge. Even after 10 years of regular promoting, many people are still unaware of our services. Oops, sorry.
All right, and this last slide, or second last slide, is a summary. And so I'll just quickly go through that, knowing that we're short on time. Who is our target population and how are they reached? Our target population are citizens of Nova Scotia who live in the greater Halifax area for the navigation services, like Cheryl mentioned. However, currently many of our virtual programs are offered provincially, and we reach people through a flyer. Usually it is a hard copy, but with our virtual times, we're offering it mainly in an online version. And healthcare providers also refer to us, as well as community partners, and we reach people through social media as well. We're on Facebook and Twitter. And the key aspects of our intervention is wellness navigation, focusing on behavior change and self-management, as well as our wellness programs. I won't review the topics again, and then our community connections, so building relationships with the partners and key stakeholders in each of our communities. And how does the intervention help? So we hope to increase citizen knowledge, skills, and confidence. We work within a behavior change model to support self-management and also connecting people to community resources to help them meet their goals. And our last slide is how you can reach us if you have any further questions or want more information. Our phone number, email, and website is there, as well as our Facebook and Twitter information. Thank you very much.
Thank you so much. I really appreciate everyone for being so excellent with presenting a body of work in a short period of time. Just a note to everyone, we are going to put a survey in the chat box just to get people's feedback and impressions. And we are really interested in what were people's thoughts on key aspects of these different models because we are actually summing these together into and understanding some of the key kind of common aspects across them as part of work we're doing in the Spark study. I think many of you heard as you were listening common elements like trust, empowerment, engaging people's strengths and coming from a strength-based perspective, engaging community organizations, engaging in navigation. I think the community paramedicine one was quite unique in also bringing it right into people's homes and right to where people are. I think the income security was unique in that it's kind of focused on a very specific determinant, whereas many of the others are more global in nature. We don't have a lot of time left because we do want to stop right at 1:30 Eastern time for folks, but I had two questions for everyone to consider, and also panelists are answering people's typed questions as best as we can too. But my first question for folks, there's several points brought up about data and the challenge of sharing data between organizations, and how does that happen, as well as protecting privacy concerns and the fact that this is personal health information. So any thoughts from really anyone around how that has been navigated? How did you deal with the issue of data flowing between organizations?
Hi.
Go ahead.
Which are we talking? Clients' medical records flying back and forth, or deliverables, or?
Yeah, more like information about a client or patient, and how does that happen? Because it's often very challenging. We often work in very siloed areas where, say there's an electronic medical record that the primary care team has, then there's community organizations having their own data systems. We're starting to see in Canada an emerging idea around integrating health and social care into bigger entities like Ontario Health Teams, for example. And so how can data actually help support this type of work?
So for the MyHealth teams, one of the requirements for partners to come on board is the use of Accuro EMR. For the Winnipeg Regional Health Authority, we in primary care, we are connected. We might not be able to see another clinic's schedule for the day, but if we are, our initial referrals come by fax. There's a record already started by that client's home clinic. We're able to search that client and document. There are some nuances. Some of our partners still use Accuro EMR, but maybe not connected to the larger system that we are. So we are able to then, if in those instances, we would document on our end, and then we would send, through the confidential faxing, a summary to that provider just to close the loop. Also, lots of phone calls. There are some tasking through the EMR for those who are connected as well, but we also do a fair amount of actually speaking to the provider. Yeah, that's our practice.
Any other thoughts from anyone else on the data question? Lisa?
Yeah, thanks. We haven't fully realized this, but it's a vision, and partially especially with the sister project in Windsor. through the Compassionate Community Care Project, but using an open source patient-controlled health record. So the idea being that if the patient owns their information, if that information from our primary care team is also situated in the person's own health record, they can give permission to other people to share. That's started to work well in some places, but it's really only a little tiny part of the start of the story there.
In the last minute or so, I just wanted to open one other additional question, which is about how organizational culture can change to embrace these types of new approaches. What have you found has worked, or what have been some of the enablers to having organizations change to actually take this on? Simone?
So maybe our intervention isn't so different from usual care, right? Because we're integrated within primary care. The navigator could be another team member. So I think we've, in the practices where we have tested the model, it's very well received. I think initially there's a bit of a hurdle in terms of everybody's is concerned about this disruption to the normal flow. But I think for our particular intervention, they are ready for that. They are ready to get the support to help their patient address their needs.
Excellent. Any other thoughts on organizational change that come to mind? Yeah, Nancy, go ahead.
I was just going to add that we often try to engage with our local physicians and healthcare providers and try to meet with them to talk about what we can do, how we can support them to take some load off of their work and their plate. So we try to, really engage them with showing how we can make their work a little bit easier. And I think through that, we get a lot of buy-in from the people that we work with.
That's great. So we're right at time, so I'm going to just conclude this. I really want to appreciate everyone's time for presenting on these 7 different models to tackle social needs in primary care. I think there's a lot of fantastic lessons that we're learning from one another. We're going to compile all of the resources that people put together and post it along with the recording for this. And please do fill out your survey if you haven't had a chance to as yet. We are also asking if people would like to stay in touch about future events. There's a chance to add your contact info. So thanks again, everyone, so much, and have a good rest of your day.
Thank you, everybody. Have a good day.
Thank you.
Thanks so much.
Thanks so much.